All right, everyone. Fred here's having a bad day, and he's going to have a C-collar put on, tourniquet put on, and the splinting. So with tourniquets, anytime we see that arterial bleeding, which is a straight stream or spurting of bright red blood, we want to put a tourniquet on because you can bleed out and die from that. So we'll say Fred here has had the misfortune of having something cut him on his lower arm, and now his radial artery is spurting blood. You'll hear, if you watch videos, of people saying high and tight. And that's what we teach our civilians, especially in the Stop the Bleed classes, to do. We want them to put it as high as possible to tighten it off. Because what we found is they're putting it too close to the wound and they weren't actually cutting off that artery, because those arteries can shrivel in. As a healthcare provider, we want you to at least do 2 inches above a joint, or if you're able to, at least 2 inches above the injury site. So Fred here, he hurt himself pretty close to his elbow, and so 2 inches would be right on his elbow. Well, we know 2 inches above the joint, so we're gonna go 2 inches above his elbow there. You can either fully remove this tourniquet and then string it through over it, or if you're able to wind it over the arm, you can sure do that too. And then you're just going to manually tighten it as much as possible just by tightening the strap. If he has an arterial bleed, then with Fred, with this twisting action that we do here, we'll be able to see the ceasing of the bleeding to know when it's tight enough. As you're practicing, if you practice on someone, the best way to know if it's tight enough is to feel their radial pulse and to twist it until that radial pulse becomes absent. That would mean that the blood flow to the artery is now cut off. So that's a good way to practice. Please only practice on adults. Children still have developing vasculature. Once you're done, then you can see a little edge here that is indented. You're just going to lock that in with the triangle and then have it held. And then you're going to want to write the time on Fred's arm, the time of administration. I always like to put it where it's going to be very obvious and in big print letters. And oftentimes the glorious EMTs that I used to work with would carry permanent markers, which is a fabulous tool. So Fred now has a tourniquet placed. If you need to, you can place more than one tourniquet. So his arm started bleeding again, place another tourniquet just above the old one. Do not remove the old one, put a new one on. And then that way you have double tourniquet action there. For splinting, Fred also broke his lower arm on this side. So what we're going to want to do is immobilize the joints above and below the injury site. And the reason for that is because if he's broken these bones, every time he moves his wrist, these bones are going to move and hurt. Same with his elbow, because they're all connected. So we need to immobilize that wrist and that elbow there in order to keep Fred happy. So this SAM splint would go all the way down. Fred is screaming right now because this is not a fun process. And then we're just going to wrap it with this wrap. Now the question of checking, what do you kids call it? CMS now, I used to call it PMS, in the extremity is important because it lets us know whether or not there's circulation to that extremity despite the bone damage. If the bones are impairing the arm's ability to circulate, then they may need to be readjusted in order for that circulation to come back. So we want to check PMS, make sure there's good pulse, motor sensory, have them move their fingers, and then we're going to want to secure or immobilize that arm as best as possible. So to do this with Fred, we take our nice triangular bandage and take it around their neck, and we're just going to do a nice little double knot. And now you have one point sticking out. You're going to have Fred pull his arm in. Fred the mannequin is not very cooperative there. And then you're going to place it so that the triangular bandage is sticking up and you've got kind of a little pouch where part of it's going interior to the arm and then you've got this little area out here. You're going to encourage Fred to put his arm there, and then you're just going to tie the loose end that you have with one of the other ends from that double knot. So now you're going to double knot again. So double knot. This is better on a human, but Fred's all I've got. This process isn't done yet. To just truly secure the arm, then you would also put it around Fred. Now obviously this is going to be problematic for a patient that's obese, but you're going to do the best you can. You can open multiple ones of these and tie them together and make it a longer double triangular bandage. But then you just double knot again. It's not a fancy knot, and you just make sure that Fred's arm's secured there. And then just tuck in that extra end, because all this is doing is just holding that arm secure there. So the other thing you're going to be practicing is collars. To measure a collar height, we're going to use our fingers, maybe 1 finger, 3 fingers, 4 fingers, and then we're going to make the height of the collar the same height as our finger measurement. So if it's 2 fingers, they likely have no neck, so then you'd leave it at no neck. Or you can, so it says no neck, short, regular, or tall, so you can adjust it as necessary. You need to unlock it, and you can do that by pushing through the tabs, and then the thing actually moves up and down. So this would be like a giraffe neck, or a lot of people are no neck. That simple thing seems easy to do, but a lot of people don't measure, and then you get misalignment with this, and a lot of times patients will come in with this in their mouths, and that is not a spinal restriction. So getting the appropriate size, locking it in, and then what we want to do is make sure that this little curved out portion goes under Fred's chin. So you might be holding that there, and Fred can't hold still, so I have to manhandle him. And then you're going to take this end that's flat, and you're going to wrap it around and secure it Velcro to Velcro. Now, ideally the curves go over their shoulders. However, humans are all made differently, so that may just not happen, and you may have to wrestle with it a little bit to get it to go around. This also seems like an easy thing to do, but when they're laying on the ground, it is super difficult for some reason to get this right. And what I have discovered is, rather than doing the chin first, I will take that flat component if Fred's on the ground, slide it under his head, get it as low as I can, and then go for the chin. Because I can pull that flat part out and kind of weave it non-traumatically as compared to trying to shove it under while I'm holding this. So if they're on the ground, try the flat part first. If they're standing up, do this. We'll work on backboarding when we're back in skills lab. The incidence again of our backboarding has diminished. It's good to know what the Canadian C-spine rule out is. And that largely entails people who have an altered mental status, who are intoxicated. If they're greater than 65 or less than 5, have a significant mechanism of injury, those are the people that we worry about still doing that full spinal restriction. But most people anymore can just be okay with putting a collar on. And if it takes less movement for them to get up from wherever they're at and then laying on your cot, which is now a mobile restriction device, that's fine. The days of using the spider straps and the head blocks are pretty well gone. The goal, even if you have them on a backboard, certainly secure them to the backboard with the straps, but you don't have to do the tying down of the head any longer, because we've shown that it doesn't work. So anytime we're putting devices on, always go back to, do they still have a pulse, motor, and sensory in these extremities? Even with the cravat or the triangular bandage placement, you're moving those bones around. Make sure he's still got good pulse, motor, sensory. If you're putting something around their neck, first of all, can you breathe is always my first question. And then second of all, feeling again for each pulse in their wrists and their feet to make sure that everything's good and you haven't affected anything. The other thing is, say Fred's neck, often with older people with kyphosis, this happens where you cannot get stuff on them. You could take rolled up towels and then just gently tape it so that it simulates a more moldable neck collar. I've seen people also use IV bags back in the days when we were using head blocks more, but you could certainly put IV bags laid across their shoulders and secure them. The idea isn't getting it so tight that Fred is tied up like a prisoner. It's to remind Fred not to move his neck. So if we can put any sort of reminder device there and then tell Fred, you know, this isn't going to prevent you from moving your head, but we're worried about a cervical spine fracture, which could kill you, it would be a good idea not to move your head. And that will remind them constantly to do that. So that's pretty well it for that. I showed you how to do the wound packing in the other video about your kits. Take rolled gauze and just keep shoving it into that hole, hacking it around the bones as best as possible to get that bleeding under control. In terms of long bone splints, again, getting a pillow, especially around the leg, wrapping it around the leg and taping it is an effective way to splint in a longer extremity. So you can certainly practice that with tape at home. Or we'll practice those traction splints and other leg immobilizers when you get back to Skills Lab. Okay, thanks, bye.